Bien, como cada año para concluir estas jornadas tenemos un invitado especial que es el profesor Thomas Berg de la Universidad de Leipzig y también del Hospital Universitario, profesor de hepatología y además actualmente es secretario general de la ISL, de la European Association for the Study of the Liver. Él es un experto internacional en hepatitis viral y también en otras áreas de la hepatología. Y bueno, pues creo que el tema COVID-19 e hígado pues se adapta muy bien a pues, lo que es el perfil de un hepatólogo que ha tenido responsabilidades no solo clínicas, sino institucionales y que ha tenido que afrontar esta tremenda pandemia. Thank you very much for coming, Thomas. We are really aware that you have a very busy agenda, so we appreciate very much your willingness to be here. Thank you.
Yeah, thank you very much, Raul. It's really a pleasure, and thank you very much for the invitation, dear colleagues, to be here in Malaga and to give a summary of what we have learned about COVID-19 and the liver. And well, there are certainly some new and interesting data to share with you. So I organized my talk in the following order, really talking a bit first of this liver involvement in COVID-19, because it's still a debate how much is this infection also affecting and infecting the liver, coming about what are the risk factors when it comes to pre-existing liver disease, are the difference depending on the underlying liver disease, and then a couple of words about efficacy of vaccination strategies for treatment and prevention. Well, the liver biochemistry, this was in hospitalized patients with COVID-19, and I think this is really from the beginning really to tell you all the data we have so far are coming more or less from hospitalized patients, and also when we had the Delta and the wild type variant, and we have less data on the outpatients, the non-hospitalized patient, and not a lot of data related to the Omicron infection. But still, I think you can, it will give you a good estimate what can be expected. And in the beginning, and these were kind of meta-analyses, it was shown that perhaps an abnormal ALT, AST is present in 20, 30%, but for more prospective observational studies, it showed here, for instance, in one US center, that then in most of the patients when being hospitalized, you can see an increase in ALT and AST, but rarely very high levels. So this led to the question of liver involvement and elevated liver biochemistries, whether this is a marker of more severe disease. And as you know, it was shown in many studies that having an increased AST, but you see, interestingly, and I will come again and again to this point, less so ALT is a marker of more severe disease and was associated also with increased mortality in these patients. So it's certainly a biomarker of more significant disease. One of the largest studies now published quite recently in our journal, coming from the Wuhan experience, they really quite carefully looked also on the trajectories of the liver enzymes, not only mentioning ALT and AST, but also the cholestatic enzymes. And I think the observations are quite revealing. So what you can see here, those in gray or in the blue curve are those patients who passed away, who died as a consequence of being hospitalized to COVID-19, whereas the others were discharged alive. And the first thing you can see with respect to ALT, there's not a big difference. The biomarker is really AST being higher in those who died and stayed relatively stable over the time, whereas in the contrast, GGG and bilirubin was in the beginning relatively low or normal, not different from those who eventually died or survived, but increased over time. And I will show you in a minute a similar study bringing all a bit more into context. And the same holds true for the alkaline phosphatase. So if you like, in the beginning, more looking like a hepatitis, AST high, and in the follow-up having more a cholestatic feature. And in this trial, they showed that also if you do all the statistics with different models, that AST and bilirubin increase stayed significant in different models as a risk factor, together with, you see here, markers of inflammation. CRP, D-dimer, you know, the thrombophilic state of patients with COVID-19, of course, the severity of pneumonia, the age, creatinine, this is troponin T. So you can calculate from this publication, according to all these parameters, the likelihood of dying of COVID-19. So the question now, if you have so many patients having elevated ALT and you see also a dynamic over the course, is there really a direct influence? Does the virus directly infect liver cells and these leading to these biochemical derangements and the poor clinical outcome? And there's really a lot of debate. And to understand these data better, you have to realize what is needed to infect cells, human cells. So you need certain receptors, and you know quite well the ACE2 receptor, that it's important for binding of the virus, but for the entry, the spike protein has to be processed, has to be cleaved by proteases. And one of the most important proteases is here the membrane serine protease 2, but also other proteases can play a role here. Then, and also the virus can also enter without these receptors just by endocytosis. But then again, furin as a protease is very much important then to process the spike protein to produce infectious viruses. And you know that still, this is still an ongoing debate whether this furin cleavage site you have in SARS-CoV-2 was introduced in a laboratory, because without this furin site, we would not have had these problems with the coronavirus too. So do we have these critical entry and processing receptors in the liver? And here you see a liver gene expression profiling of all the different cells, like hepatocytes, cholangiocytes, and other endothelial cells. And you see here the expression of albumin quite high. And you see, of course, ACE receptor and also furin, or the protein serine protease, is less expressed in hepatocytes. ACE receptor mainly expressed in cholangiocytes. And you find the protease also in sinusoidal cells, and furin in most of these cells, but not with a very high abundance. And when you come to cell culture, you can see SARS-CoV can infect a various number of cells. It's not restricted to lung cells. And in comparison to the previous SARS-CoV-1, you see SARS-CoV-2 infects more efficiently the lung, perhaps less efficiently the liver, and less efficiently the gut. And this was well known during SARS-CoV-1 infection, that many patients had gastrointestinal symptoms. We see them also, the gastrointestinal system symptoms also with SARS-CoV-2, but to a lesser extent as compared to SARS-CoV-1, and also organoids, cholangiocyte, hepatocytes organoids, but also pancreas organoids can be infected by SARS-CoV-2. So this is a most recent publication in Nature Letters, giving a strong argument that SARS-CoV-2 can infect the liver and can do a lot of derangements. Coming from the Hamburg group, and they also systems biology, system medicine approach to really prove that SARS-CoV-2 has a liver tropism. First of all, they also realized in their department that most patients being hospitalized had elevated ALT and AST, again, AST more often than ALT, and that it worsened over time. A clear evidence that there's something going on in the liver during the infections. They tried to recapitulate, to prove it, to validate it with a large cohort from Michigan. Most of these patients had not so many comorbidities, were not so old, so it's really here, mainly liver involvement. Again, 57% had elevated liver function test, although only a very minority had a pre-existing liver disease. And again, they saw this trajectory in the beginning, AST high, then normalized, but in some of them, and this is a bit different from what I've shown you before from the Wuhan experience, also in the end, an increase in AST, less so with ALT. And then they did a lot of these studies and showed that with immunofluorescence, they could show the ACE receptor, they could show the spike protein in cells, ACE mainly in Kupffer cells, whereas the spike protein immunofluorescence was shown in Kupffer cells and hepatocytes. They could show the expression of the proteins in the human liver here with ACE, but also with the spike protein in many cells, Kupffer immune cells and hepatocytes. And they tried to find whether, like this Koch postulate, you have to find infectious viruses from the organ. So they attracted the viruses, put it on cell cultures, and saw that they are replicating viruses and in different cell types. And then again, they showed the molecular signature with gene expression analysis. And it was interesting to see that the highest similarity in gene expression profiles were seen with HIV infection and with a more mild hepatitis C virus infection, giving a strong argument that this infection induces something that looks similar as we see in viral hepatitis infection. This was the editorial by Ellen Barnes showing how we may think about it, how liver become infected. So the virus, after ingested, if you like, enters the liver by the GI tract, and then this is the hypothesis, infect cells, and have shown you all the data giving evidence that it's directly infecting hepatocytes and thereby causing the damage with the increase in AST. If you look in autopsy studies, what you can find histological, and of course, these are the most severe cases, died because of COVID-19. I think if you see these most important features like inflammatory portal or lobular inflammatory responses, this is rarely seen. The typical picture you normally have is a viral hepatitis. A hallmark is really vascular changes. You find these thromboses, endothelitis. You have here, as you can see, also congestion of the hepatic sinuses, bile plugs, and I will come later to this, mitochondrial dysfunction and apoptosis, and sometimes also steatosis you will find in this liver. But I think, and this is really shown in most of them, you find vascular endothelial changes with microthrombi. And again, and this study is never cited by all these other publications because perhaps it was published in biomedicine, people are not aware of. It's really a huge study confirming what all the others found, but published some 2 years before the other papers. So they again looked at the trajectories of the different liver enzymes. And, I think we as hepatologists are quite good in dealing, is it more hepatitis, cholestatic-like, AST higher than ALT? This tells us something. And again, ALT, AST, no difference in those survivors or deceased. Again, AST higher in those who died but stayed stable. GGT normal in the beginning, but when the patient died, it was higher. The same with alkaline phosphatase, albumin was low, and you see here high resolution, CRP, very high in those who died. And then they correlated it to other clinical features, and they saw that the oxygen saturation was negatively correlated with AST, but not with GGT. And well, this I've shown you that the liver function in abnormalities increased. So for me, and I think you're quite aware in the clinic, if you have patients with high AST, this normally tells you it's a different pathology and can be really linked to ischemic lesions. So for me, a strong argument that here in the beginning, it's more a ischemic type, and then secondary, it's more a cholestatic pattern, perhaps not so well understood what is going on there. And this is also confirmed in a way when they looked what is correlated to elevated liver enzymes, especially AST. they thought that these trajectories of liver function appear to be highly correlated with inflammatory markers. Again, speaking more for an indirect effect on the liver by cytokines and this systemic infection. Are there any long-term consequences in these patients? Well, perhaps you have seen these patients after a severe being critical ill, being on the ICU, seeing the sclerosing cholangitis in these critical ill patients. And this is a very interesting study. So is it specific to COVID-19, or do we see it in a similar way in patients being on ICU, let's say with influenza, with other virus infection? And this coming from Zurich, and they had a similar number compared of ICU treated patients with influenza or COVID-19, and they looked for cholestasis and for the death rate. And the first interesting observation is that cholestasis is much more often seen in patients with COVID-19, whereas those with influenza normally had no cholestasis. On the contrary, when it comes to the death rate is correlated with cholestasis in COVID-19. You see starting from 7 to 56, although the numbers are low in those with severe cholestasis, whereas in influenza, most patients, nearly all, died without any cholestasis. And the risk of secondary sclerosing cholangitis was seen in those with severe, but no case in influenza. And you see here again, the peak ALT levels related to mortality outcome and related to the outcome of the secondary sclerosing cholangitis. And you see again, those patients had very high AST level. This could be indicative that there might be also an ischemic type injury of the bile ducts. Here are histological findings. You see here with the cholestasis and the destruction of the bile ducts. And this comes from Michael Trauner from Vienna, and he will present during ILC some of these data. And he looked in liver disease patients. Most of them had fatty liver disease, NAFLD, and he showed that fatty liver disease or chronic liver disease is a risk factor for this type of bile duct injury, where he found 15% of patients with underlying liver disease when they had COVID-19 developing this secondary form of cholangitis. So I would like to move forward to the question whether a pre-existing liver disease is indeed a risk factor for severe COVID-19 or death. And from the large NHS, National Health System in England, you see here it's a population-based study, if you like. Chronic liver disease appeared to be a risk factor for more severe COVID-19, but also death. From the data of the registries, also the EASL-HEP, COVID-HEP registry, it appeared to be a bit different interpretation, linking liver disease to age on the one hand and to comorbidities on the other. And you see here, these were all patients with chronic liver disease, and the reds are those who died, the blue are those who survived. And you can see here, if you have no comorbidity and you are young, you do not die, although you have liver disease. But if the numbers of comorbidities increases, and of course the age increases, then you see more deaths. So here it was more perhaps liver not an independent factor. And if you look at certain diseases, for instance, well-controlled hepatitis B under treatment, you see no difference in the survival curve. The same with autoimmune hepatitis being under stable immunosuppression, no difference. And this is confirmed here in the US. But we have the overlap perhaps with liver disease, and the most common liver disease is fatty liver disease and obesity. And I think we all are aware, if we have treated patients, that from the beginning, when we had young patients with severe disease, they were quite often obese. And obesity, you see in a clear relation, is a certain risk factor. So the question is, what makes obesity a risk factor? And it could have something to do with viral replication in the adipose tissue, because here it could be a hub for viral replication. And on the other hand, we know that patients being obese might have a pre-activated immune system. So, and under this condition of having a pre-activated immune system and then COVID leading to this cytokine storm, this may have deleterious effect on this cytokine storm. And we know that obese patients are also more at higher risk of micro or thrombi. So this may, this hypercoagulation state may in addition have a consequence on immune, on organ perfusion when you think about microthrombi. So I think it's an interesting question whether really COVID-19 and obesity, non-alcoholic fatty liver disease are two intersecting pandemics, and that we were severely hit by this pandemic because we are having these certain risk factors in our populations. And coming to the fatty liver disease data quite briefly, it was shown first here, publication from Hong Kong, that patients with NAFLD had a higher risk of disease progression, higher likelihood of abnormal liver function, and a longer viral shedding as compared to the non-fatty liver disease. You see also a difference in the D-dimers in patients with NAFLD being higher, with a higher peak concentration, in a way confirming these hypotheses that obesity, fatty liver are linked and have a more pro-thrombotic profile. And I think this is perhaps really the most interesting study, giving good evidence that perhaps really NAFLD could be also an independent factor, especially in the younger population. If you're very old, perhaps then the age, being 70, 80 years old, is so dominant that you can't see any more effect of NAFLD. But for the younger population, you see here the odds ratio can be quite high. And the reason could be that by certain changes with the disease, also the receptors and the proteases you need to process and to replicate the virus may change. We have shown, or it has been shown, that also in cirrhosis, ACE receptor is going up. And the same here with NAFLD. If you have NAFLD, you're obese with NASH, the critical entry receptors are increased. And it seems that you do not have to have NASH that this may happen. These are women for bariatric surgery, and 23 had just steatosis, no NASH. But having steatosis and NAFLD, so NAFLD without NASH, showed an increase in the subcutaneous, in the visceral adipose tissue, but also in the liver with higher expression of these entry receptors. And I like this study because it again links a kind of intersecting pandemics. What they have done here, they looked for gene expression profiles, and they looked for those genes that have been linked to COVID-19 and looked, are there other diseases having a similar expression profile? And the two other diseases with the highest similarity in the expression profiles were leukemia, you can see it here. The more yellow red, the higher the higher the similarity in the expression profiles, and NAFLD as shown here, so that it's likely that these similarities in gene expression pattern offer a favorable environment for fatty liver disease patients for COVID-19. Well, I have half an hour, right? And we started a bit later, so I think still 10 minutes or so. A very brief word to pre-existing diseases. I think most of you are quite aware what's going on here. The highest risk factor is really cirrhosis, and especially decompensated cirrhosis. And then depending when you're hospitalized, from child A to C, up to 54% mortality in these patients. And if you're admitted to the ICU or you need invasive ventilation, then nearly all patients with a child C cirrhosis die. They do not all die from liver failure, but some of them, as shown here in an Italian study, still COVID-related mortality is a bit higher, but also other patients may develop ACLF as a consequence of this infection. And the reason why these patients are at higher risk, well, again, it could be, you know, you heard about ACLF, that there's also an immune activation on the one hand. This could lead to a more severe disease. On the other hand, you have the immune paralysis that could also influence the situation, or that you are less responsive to the vaccine. I think there's one part perhaps missing here, and this is how patients were handled. And here we come a bit to the stigma of patients with cirrhosis, especially when it comes to patients with alcohol, or what is proposed to be alcohol-induced cirrhosis, in a situation where you have perhaps make decision because of, how many beds you have in your ICU. And what is really very nicely shown here in this study from France, where they looked on all the in-hospital mortality of patients, and you see it's really a population-based study. They thought that alcohol use, decompensated cirrhosis, primary liver care were all associated with a higher 30-day mortality, but in the same way that they have a lower likelihood of being treated on the ICU. So there can be a kind of selection process going on in who deserves the scarce beds on the ICU during a pandemic wave. Liver transplantation, well, a few words, starting first with a European very nice collaborative study showing whether liver transplant patients are at higher risk of mortality. And if you look how many patients died here, it looks quite remarkably, the overall survival not very good. If you stratify by where patients were managed at home, on the ward, ICE, you see a huge difference. But when it comes to risk factors, it appears that again, age was very much important, and whether the patient had chronic liver disease, and interestingly, being treated with tacrolimus or tacrolimus was associated even with a better outcome. So perhaps the cofactors are more important than the transplant. And this is also the message coming here from the registries, where transplant per se was not an independent risk for severity of disease. This is a Spanish cohort showing first here the incidence rates, the epidemiological. So what you see here are the number of people being infected after transplantation with a liver transplant. And here you see the overall population-based infection rate. And you see it's clearly in the same slope. If the overall general population, you have a high infection rate, then you also have a high infection rate in your transplant patient. When it comes to this incidence rate, it seems that indeed the incidence in transplanted patient was higher, according to this study, nearly twice as high as in the normal population. But the standardized mortality ratio was in fact a bit, but still significantly lower as compared to the overall population. And again, they could show that the type of immunosuppression matters. If you have mycophenolate, this is a risk factor for death, especially if you have high doses of mycophenolate, and they propose that you do not have to change your immunosuppressive regimen. It might perhaps even be beneficial if you have, let's say, CNIs, but if you have mycophenolate immunosuppressive regimen, consider withdrawal, and if it's a monotherapy, switch to another approach. I think in the interest of time, I will skip this one and want to come for something that is now very heavily debated. And this is whether the vaccine, and by vaccination, especially with the mRNA vaccination, whether you can induce hepatitis, and whether this is a kind of an autoimmune hepatitis. And I think you have heard about this. And this was the first case published here in J. Hepatol. You were very brave to believe in the story. And this is not a coincidence, but perhaps really related. And you see here a patient after the, or a person after the vaccine, without any liver disease, by the way, who suffered a severe ALT increase. He was then put on prednisolone and improved quite rapidly. And they saw features also with these rosettes and the inflammation, the profile of the inflammatory response. It really resembles autoimmune hepatitis. And when you look at other cases, quite often you can find antibodies. You have typically high ALT levels, and you have more often a female predominance, but it's not only found in the mRNA vaccination, also in the Oxford, what is called Oxford AstraZeneca. Even reactivation was seen if you revaccinate in one patient, quite, I think, convincing that it's really linked to the vaccine. You see here the first, then a second dose, again an increase, and then treated with prednisone, and it resolved. The largest, let's say, data collection has now recently been published, and they collected 87 patients, again, more female. The age is relatively young, and the liver injury after vaccination was diagnosed in a median of 15 days. So it's a clear link time-wise to the vaccine. And you see here most of them with an mRNA, but also 23 with the Oxford. And they saw predominantly a hepatocellular liver injury and features of immune-mediated hepatitis. Corticosteroids were given in 53%. Resolution was seen in all but one who need a liver transplant to liver failure. And then steroid was withdrawn, and in none of the patient after tapering, steroids were withdrawn, they saw a relapse, but perhaps we need some longer follow-up for these patients really to see whether there's might be also a kind of an induction of really an ongoing autoimmune process. And this is very interesting, and I would like to recommend to you to look at this paper because it contains really a lot of interesting information coming from the Freiburg group, Robert Timmer and Tobias Böttler. They had a patient that was primed, if you like, with the first vaccine and developed an hepatitis, but nevertheless get a second dose, and then visited the center, and they did a liver biopsy, but also took blood samples, and they did the whole profile, immune profiling, and they could show that it's really a CD8 T-cell mediated hepatitis. The infiltrate in the liver was nearly purely CD8 mediated hepatitis. And this is a very interesting observation. Unfortunately, the Chinese, but also Fox News took this up. I don't know whether you have seen, it was a lot in these media because, you know, the Chinese are fighting a bit against this mRNA technology because they don't have it, and say, here, look people, how dangerous these mRNA vaccines are. And the same did Fox News. Well, is this something specific, and is it therefore really a concern of the vaccination? And you know, there is also concern of this multi-systemic inflammatory response that has been seen in children, called this MIS, hyperinflammatory syndrome. And they did a post-authorization pharmacovigilance study after the vaccine and looked for this type of multi-inflammatory response in children. And you see the huge numbers of more than 8 million that were did, and they found 12 in the children with these, and 50% of them also had, among other symptoms, a cytolytic hepatitis. So the reporting rate was 1.5 per 1 million, 2.9 per 1 million doses or children being vaccinated. But in comparison, this multi-system inflammatory response is a well-known feature of COVID per se. And if you look at these, how often these systemic inflammatory responses happen in patients being infected, it's 113 in comparison to 2.9. So clearly, again, favors, and it's important to explain this to the patient. If you are more susceptible to this type of reaction, it's more likely that you can get this by a natural infection as compared by the vaccination. Yeah, well, now you have heard about this unclear hepatitis in children, and if you see something new and the pandemic is running, you may wonder, has this something to do with COVID-19? I think so far we can't really exclude it. In some of these children, a coronavirus was found, but also this adenovirus. There's a new public health corner in the journal, so you may watch it in the EASL studio next Tuesday with a special EASL broadcasting on this topic. coming from the journal on this unexplained acute hepatitis. ECDC, WHO representatives are there, and also the surgeons that transplanted some of these children. So it will be, I think, a quite interesting studio session. I would like to come to an end and just to remind you that, of course, we are now much better prepared as we were 2 years before. We have vaccines, but not only vaccines, we have antibodies for preventive and we have antivirals. And if you are interested on the EASL position, how you handle this, I would like really to refer to this publication. Of course, we are really asking for prospective registries to really see how a liver disease affect your vaccine response. And these are the couple of slides I would like to show you, that we have now first data clearly showing that patients after transplant do respond less well to the vaccine, with only 50% positive antibody response after 2 vaccinations. These were these early days. And again, age, as always when it comes to the vaccination, eGFR, so if you have kidney dysfunction, the response is less. And again, mycophenolate play a negative role in the response. So what can you do if you have the booster? Of course, you see here's the second dose. Before you start the third dose, you see already that the antibodies are going down. These are all solid organ transplant, not only liver transplant patient, but you can significantly increase it after vaccination. And the liver is more responsive than the other organs, perhaps because you need less immunosuppressive agents. And again, CNIs are not a risk factor, but mycophenolate or azathioprine is a negative predictor. So the question is, should we stop it before vaccination? And this is what some kidney transplant physicians did. They stopped 5 weeks before the next vaccination in non-responders. You see here no response. And by doing this, they were able to induce in 76% response. And these are the only data related to Omicron coming from Israel, most recent, where they looked on, again, high-risk population, and these are in the age between 60 and 100 years old. And they looked for a second booster. And the outcome here is mortality from COVID-19. So this is not related to transplant, but I think it's in a way revealing that if you do not have a response, for instance, in a transplant patient with certain risk factors, that by a booster, it's likely that you do something good and that you can reduce mortality. Well, I just want to make you aware that there's, again, perhaps, I don't know whether there will be a final position paper, and this is really also related to what you can do in treatment. And with respect to vaccination, of course, we clearly recommend vaccination. We are aware that we can't really tell you what is the optimal scheme you should do. 3 doses of vaccine or equivalent 3 exposures to spike protein means if you have 2 vaccines and then Omicron infection, this means also 3. But we think that in some situations, high-risk situation as transplant patient, perhaps a second booster would be something reasonable. And we are also addressing the point of preventive treatment. This is too complicated really to explain here in a talk, but overall we really recommend monoclonal antibodies, but also the antivirals even early in the phase, because only then you're effective. In the early stage where there's viral replication, antivirals are not any more effective if you are in the inflammatory response phase in patients with a certain risk. And we also believe that patients, with decompensated are considered immunocompromised in a similar way as the recommendations are, and we are more in favor of giving passive immunization to these patients. So with this, I want to end, and of course to invite you all in 4 weeks from now to join EASL's ILC and to see you in London. Thank you very much for your attention.
Thank you very much, Thomas. Thank you for this excellent presentation. Plenty of new data and absolutely covering everything in the field of COVID-19 and the liver. There are any questions or comments? I would like just to to ask you about this secondary sclerosing cholangitis, because Einar knows very well the syndrome is associated also with the use of drugs, and maybe that some of these patients that were in the intensive care unit could receive at the same time having COVID-19, severe COVID-19, receiving any drug that are being involved in this syndrome. Do you know something specifically about that?
Yeah, perhaps the numbers are still not high enough really to draw a firm conclusion, but of course this may play a role. And I think these typical, let's say, jaundice on the ICU, we always claim it's multifactorial even without COVID, and of course medication can play a role, but it's so difficult really to dissect what is the most important driver in this situation. So to be honest, I can't really give you a firm conclusion. There is the one, I'm just missing the type of sedation treatment that was linked. Do you know? Yeah, ketamine, sorry. Ketamine. There's a suspicion that ketamine you should at least avoid in patients with COVID when it comes to mechanical ventilation. Yeah.
And I have another additional question. What is the meaning of, in your opinion, of persistence of liver test alteration in patients once they are recovered from COVID-19?
To be honest, I haven't really seen a clear, let's say, long-term consequence in terms of a chronic hepatitis or so. But several patients with really very severe secondary sclerosing cholangitis. And in my view, but again, it's anecdotal, they had really a more rapid deleterious course, as we know from other patients with ICU-related secondary sclerosing cholangitis. Many patients really died before they get the transplant. They were in very bad condition. This is, well, perhaps we really need more data collected to get a better picture here. I don't know how many patients you had in your unit and whether you had the same experience.
I had only, anecdotal experience on that. And sometimes the liver tests come back to normal. No?
This is what we normally see. If they resolve, then the liver enzymes resolve. So the only long-term consequences I have seen are really these cholestatic sclerosing cholangitis, ischemic type lesions.
Einar?
Thank you for this excellent presentation. I think you showed one control study. Most of these studies have not had a control group with COVID in the ICU and in hospitalized patients in liver tests. We did a study in our country, several hundred patients hospitalized, and compared them with the swine flu. I know the in time. There was a very surprise that elevation in liver test was very similar in the two groups. And we were disappointed, if you can say that in the COVID-19 with all these liver tests, we had no really serious outcome in the patients.
Yeah, that's interesting and a bit, but have you seen also some with these sclerosing cholangitis? Because this is a bit the message from the Swiss group. And I also talked to Beat Mühlhaupt, who is a senior author. He really felt this is really something in there, and as the same impression from Michael Trauner's group, that this is a bit different from the typical, let's say, sclerosing cholangitis, or let's say the frequency is a bit different. But I fully agree. We also see it in other patients with having a very severe course. I think interesting to get your thoughts. What I normally see also in these patients with this secondary sclerosing cholangitis, that they had typically when they come to the ICU a shock, with AST levels of 5,000 and so on. And then always my feeling was, well, due to the shock, they had ischemic biliary lesions. And this is not so typical here. They do not start with a shock immediately. It's more a slow progression with several organ failures and yeah, of course, starting with the lung.
So I was a reviewer of the paper and live in international, so I get them to be a little bit moderate because it's very difficult to distinguish from other patients.
Yeah, absolutely.
Due
Fair
to
comment and fully
critical
agree.
care illness, you know, it's a lot of information from Germany.
Yeah.
Any other question? So thank you very much again, Thomas.
You're welcome.
Fantastic.
Thanks a lot.
Thank you. Bien, pues llega el momento de cerrar estas jornadas como cada año. Nuevamente mi enorme agradecimiento a ponentes, moderadores y por supuesto a todos los que estáis aquí, ¿no? Atendiendo, y también a aquellos que lo hacen online, ¿no? Estas jornadas que realmente tratan de poner en actualidad pues muchos temas de interés en hepatología. Y dicho eso, pues yo quería además agradecer a la industria farmacéutica su apoyo para hacer posible que podamos traer también pues, ponentes de distintas partes, no solo de España, sino de otros países. Y es una colaboración que es imprescindible para la calidad, mantener la calidad del curso. Por tanto, mi agradecimiento de nuevo. Y también, de forma especial, también quería agradecer a las personas que dan soporte tecnológico a que las jornadas se puedan retransmitir en streaming, ¿no? Y en directo, que son pues, del CTI de la UMA, Álvaro Hidalgo, Mario Ferrer, Isabel Barrajón, y de Sombra Doble, Carlos Martín. Muchísimas gracias, creo que todo ha ido perfecto, no ha habido ninguna incidencia, ha sido realmente algo pues, que casi no es ni español, porque en España suelen fallar las cosas, pero parece que ha sido de otro país. Bien, y también agradecer, por supuesto, a la logística de Viajes Challenger, que da soporte pues, a todos los que vienen de fuera y también que pues, nos atienden durante las jornadas en todas nuestras necesidades. Muchas gracias. Y por supuesto, os convoco el año que viene a las nuevas jornadas que serán, ya está decidido, siempre son en la tercera semana de mayo, y esa tercera semana tocaría el año que viene, en el año 2023, los días 18 y 19 de mayo. O sea que apuntarlo en vuestra agenda, bloquearlo para que no tengáis ni primeras comuniones, ni bodas, ni nada. O sea, prohibid los eventos familiares y sociales en esos días. Y bueno, también quería agradecer, que no está aquí ahora mismo, a Aurélie Papineau, que ha hecho una labor también de organización fantástica, dando apoyo incondicional a cualquier y resolviendo cualquier problema que ha habido durante la gestión del curso. Pues nada, muchas gracias a todos, que paséis un buen fin de semana y hasta el año que viene, en esta jornada.